if you I don't consider myself an expert in anything, especially not computer science and engineering, but if you learn enough of the language to speak intelligently with other people, then you can work together like that. So you can be the translator, you can help guide the project. So that's what I tell the residents that I volunteer teach informatics to some residents. And I always tell them, you don't have to know everything about informatics. You don't even have to like it, but you just have to be able to speak intelligently about it. So when you're working with technical people, you can at least understand each other.
Welcome to the People of Pathology podcast. I'm Dennis Strank. On this podcast, we explore pathology one story at a time and connect with the people behind the diagnosis. My guest is Dr. Derrick Forchetti, a hematopathologist with a strong interest in informatics, digital pathology, and artificial intelligence. We'll talk about how his early interest in computers and technology eventually merged with his pathology career. Dr. Forchetti shares a practical, real-world example of how AI and digital pathology could be used to predict cancer risk and help guide personalized treatment in the future. All right, so let's get into this conversation with Dr. Derrick Forchetti. All right, Dr. Derrick Forchetti, thank you for being here with me today.
You're welcome. It's my pleasure.
All right, this is going to be an interesting and fun conversation. So I want to start with you back at the beginning. So you went to medical school, the Indiana University School of Medicine. And I'm curious back then, like what experiences or mentors led you to pathology?
Yes. So Indiana University, the medical school has branch campuses all over the state. So you can attend, when I was in, you could attend your first 2 years of medical school outside of the main campus. So I was at the Northwest Center for Medical Education, which is in Northwest Indiana. And actually one of our pathology instructor was a community pathologist in a town just maybe 15 minutes away. So he was a regular working pathologist, but he came in a couple days a week and taught us pathology, and then gave us a tour of the lab one day and showed us everything, microbiology and all of that. So I didn't really know much about what a pathologist did until then. So we had a family friend who was a pathologist, but didn't really know what he did. But his name was Dr. Huang, and he really was a very engaging person, a good teacher, and really got me excited about pathology, especially when I saw all the different things in the lab. You know, it covered everything in the hospital, and it wasn't just looking at anatomic pathology, there was clinical pathology and all of that. So I thought it was really exciting that you could participate in almost every aspect of patient care just by being in the lab.
Yeah, for sure. You said that you didn't really know much about pathology at that time. Do you think that's still the case for medical students?
I think so. Yeah. I don't think there's much exposure to when you get, your pathology course is mostly just the basic science about pathology. And I had no idea what a pathologist actually did. And I think that's still the case. I think there's a lot of effort from the CAP and others to expose medical students to pathology.
Yeah.
So hopefully it's getting better, but I think most people really don't know what we do.
Mm-hmm. Yeah, I agree. I mean, I work at a place that has pathology residents too. And from talking to them and other people, like you said, it's getting better.
Yeah.
There's a lot that's being done about it, but we still have a ways to go.
Yes,
Yeah.
we do.
Yeah. From there, you went on to specialize in hematopathology. And like, where did that come from? What was that inspiration?
That came from my residency program. So our program director, her name was Dr. Janet Repke. She did a fellowship in hematopathology at the University of Utah, and she was an excellent teacher. So I've learned so much from her just in my regular hematopathology rotations and residencies. She taught me so well and just made it so interesting. And I learned so much that I really felt I enjoyed it. And then I really felt prepared to do to do bone marrow interpretations and lymph nodes and things just from her instruction. And the training program I did was interesting too. So we had a few other residency programs, but it wasn't a large academic center. And nobody wanted to actually do the bone marrow biopsy procedure, so the pathology residents actually did all of the bone marrow biopsies themselves. So
Oh, wow.
I got really good at doing bone marrows. I got to talk to the patients beforehand. We got to go up in the hospital and we would leave a procedure note in the patient's chart when we did a bone marrow and things like that. So that made it much more real to me also, to see the patients and to be part of the procedure. So she really inspired me and put a love of hematopathology into me.
That's interesting. So two things about that. One is, and I've heard this many times from different people I've talked to, but the influence of a mentor, if she had been, it had a different subspecialty, maybe you had gone in a different direction, but because she was a hematopathologist, that influenced you. Do you know what I mean?
Yeah, for sure. I mean, that definitely was a big part of it. I mean, I sort of always had a little bit of an interest in it, but yeah, if she had been a pulmonary specialist, I might be really interested in lung pathology or something like that. So
Yeah. Yeah. And the influence of mentors is very important.
she, I thank her every time. I don't do it enough, but I need to thank her all the time for just, the gifts she gave me. She just taught me so well. So I'm so appreciative of that.
Sure. I can understand that. And the other thing is, it seems like hematopathology it's a combination of clinical pathology, anatomic pathology, and then, like you mentioned, you have a little bit of that patient interaction aspect to it. So it's got everything.
It's got a little bit of everything, and it was right at the time when the WHO classification the first one just came out, so we went from, like, the real classification and some of the old to the new WHO classification, so that also made it really interesting, and, yeah, it's fun. I feel like it has its feet in both, on both sides in the clinical pathology and anatomic pathology, so it makes it interesting.
Okay. Yeah, that makes sense. One of the main things I wanted to talk about with you, because for a lot of pathologists, they might become interested in informatics maybe later on in their careers. But for you, it was much earlier. It was towards the beginning. And I'm curious, like, what sparked that interest?
Well, I'm a nerd, huge computer nerd.
Same.
So, yeah, well, I saw somehow my middle school Apple was giving away free Apple IIs to schools. So my middle school, this is like early 80s, got an Apple IIe. That was the first actual like real computer I saw. And I'd just been so interested in that ever since. I begged my dad to buy an Apple, and he never heard of a company called Apple, and he wasn't gonna waste his money on that, but he had heard of IBM, so he
Okay.
bought an IBM PC for himself that he said he was gonna use, and he didn't even turn it on once, so that became my computer. So I've always been interested in computers, computing, and and then as I went through medical school and residency, I was always looking for ways to mix technology with medicine, and how can we use technology to take care of people, do a better job in patient care and all of that. And then I got a chance to go to an API
Mhm.
meeting when I was a resident, and that was sponsored by Aperio, and I saw their first line scanner there, which I thought was very interesting. And I was all ready to do an informatics fellowship. I was, or at least applying for one at UPMC when I was finishing my residency. And then but I got a job offer and I already had 2 children. So I decided, instead of one more year in another different town and, low salary, I decided that probably to support my family, I needed to get to work. So I took a regular practice job, but I don't know, I've always that first, it was kind of a weird, like, epiphany moment or something when I saw that first computer. I just thought it was the coolest thing I'd ever seen in my life. So,
Yeah, I can remember. I'm probably about the same age as you, because I can remember in my grade school they had a couple. They must have been Apple two E's, I think,
mhm.
and they were
Yeah.
giant.
Uh-huh.
And I remember just being fascinated with, like, not having any idea what it could do.
Yeah, and the double disk drives and
Oh yeah,
that whole thing, and yeah, and then our science teacher, like, showed us this program, and I thought, "Wow, this is just," it was amazing.
yeah, yeah, for sure. Now you're going along, and you said you were trying to think of ways to combine like medicine and technology. You do have any idea, where we are now? Do you have any idea, like, that was the trajectory, I guess, for this kind of integration?
Not really. I mean, when I saw that scanner, I thought for sure
Mm,
digital pathology would be a thing, and I kept wondering when it was gonna happen. That I foresaw because there's the parallels to radiology and things like that, where they went from film to digital pictures, so but as far as the machine learning and the AI and some of the newer developments, I didn't really anticipate how fast that would sort of take off and explode.
mhm.
Um, I guess that, that's it that everybody no I think everybody's kind of blown away by how fast some of these AI things are taking off. But so no, I don't think I anticipated all of it, but digital pathology I thought was something for sure would happen
Mhm.
at some point.
Okay. Okay, that makes sense. You did some work with Google for the Google Medical Brain with
Yeah.
topics like digital pathology and AI. How did that collaboration start?
That started, with a colleague of mine. He did his dermatopathology fellowship at UCLA, and somehow he got hooked up. They were looking for pathologists to be like subject matter experts, and so he was working for them, and he mentioned it to me, and he said, "You should email them and see if they're looking for people." So I emailed them, and they got back to me, and they said, "Yeah, we're still looking for pathologists." So, I mean, they did pay us, but I was really more interested in doing it just to see what they were working on, and it was more of a interest than just for the extra income. So, I can't really say what we did because it's all top secret, but,
Of course.
it was very interesting just to see what projects they were working on, who where they got their information from. It was supposed to be anonymous, but sometimes you could still tell where some of the patients came from and things like that. So it was a bit of a challenge. I didn't really feel like I was working for Google. And in fact, they told us that like every 5 minutes, in every orientation thing, they said, you don't work for Google. You're not a Google employee. You don't get any Google benefits that Google people get. We worked for a third party. We were like contractors hired by a third party
Okay.
to work for Google. So, and sometimes you sort of felt like you were out of the loop, like they were probably doing a lot more stuff, but you didn't really get a lot of communication directly from them. But it was very rewarding. It was kinda tedious. It was a lot of annotation and a lot of delicate work that we had to do, but I really enjoyed it. And then they just somehow kind of pulled the plug on the whole thing, and I think I'm technically still employed, but I
Okay.
haven't worked for them in a long time.
Okay. So it must have at the time at least kind of scratched that itch for combining pathology with technology, right?
Yeah, for sure. Yep.
Hmm. Okay. And do you think there's anything that you take from that experience that you bring, with you to your work today? If does that make sense?
Yeah, yeah, I think one thing I thought is the tools and things that they were building. I thought, there's no reason we couldn't do some of those kinds of things ourselves. Then the software and the things that people use to build these tools are available to everyone. Everybody uses a lot of the same open source s- code for machine learning, for vision learning. I can't remember the exact term, but
Oh, yeah.
all of these things like PyTorch and all of these software packages and things, it's all out there. So I
Mhm.
thought, you know, why we could do the same kind of things that they're doing,
Oh, I see. Yeah.
at our own institution. If they're making a tool to help pathologists diagnose this or look for that, we could do the same sorts of things, I thought. So,
That's interesting. Okay.
yeah.
Um, you've described your work as bridging the clinical and technical realms, and I think we kind of talked about that a little bit already. I'm
Mhm.
curious, like, if you're a pathologist or clinician working with engineers, are there some challenges to kind of working together on, say, AI tools?
Yeah, I think the biggest challenge is engineers I mean, they can solve just about any problem that's out there, but the challenge is they don't know what the questions are. And I think a lot of times they'll come up with solutions that aren't a problem. And it's difficult to sort of, you don't ever want to say, well, that's not, bad idea because they're all good ideas, but some things just aren't a question that there aren't, that just doesn't need to be answered. I always think of like you could design a system to grade nuclear positivity, but very accurately, like it's 90.3875% positive. But right now, you really don't need that degree of accuracy. 80, and there's not much difference clinically between 80% positive, 90% positive, 70% positive. So I think that's the difficult thing is an engineer would want to build this fantastic tool that would grade it so accurately and so well, but then you just have to step back and say, well, that's not a question that really needs to be answered
Hmm.
right now. So I think that's one of the biggest challenges, but that's the benefit of then working together because they have the technical know-how. They know how to solve the problems, but we as clinicians and laboratorians know what the questions are that need to be answered. So it's really beneficial to work together like that.
I can see that. It has to be difficult sometimes because it's almost two different languages, I guess, in a way. And it has to be hard to translate that sometimes.
Yep, it is. But that's I don't consider myself an expert in anything, especially not computer science and engineering. But if you learn enough of the language to speak intelligently with other people, then you can work together like that. So you can be the translator, you can help guide the project. So that's what I tell the residents that I volunteer teach informatics to some residents. And I always tell them, you don't have to know everything about informatics. You don't even have to like it, but you just have to be able to speak intelligently about it. So when you're working with technical people, you can at least understand each other.
I think that's really good advice. I mean, as technology becomes more and more involved in pathology, yeah, having that at least basic knowledge of informatics would be super valuable.
Yeah, just enough to know, like I said, speak intelligently about it,
Mm.
know enough to understand what people are talking about. And you don't even have to like it. You don't have to be a computer nerd but you have to know enough to talk about it.
Yeah, yeah, that's great. I love that. I love that. This is the People of Pathology podcast with our guest, Dr. Derrick Forchetti. We'll be right back. When it comes to cancer staging, one of the most important parts is finding all of the lymph nodes. I should know, it's what I do every day. Yet this process has remained the same for over 100 years, manual, tedious, and time consuming. That's a problem because every missed lymph node can mean inaccurate cancer staging. That's about to change. Enter InVision from Cision Vision, a first of its kind device that's redefining the standard of care. Traditionally, we identify lymph nodes by sight and feel alone. InVision changes that using short-wave infrared technology to make lymph nodes stand out clearly from surrounding fat and in real time. In its first 104-patient study published in the Journal of Clinical Pathology, InVision helped increase lymph node counts in 86% of cases and even upstage 4% of patients from N0 to N1. I personally contributed to the study, and let me tell you, seeing the technology's impact firsthand was amazing. It's time to invest in grossing innovations that improve patient care. So, how is your lab approaching innovation in grossing? Book a demo at demo.cisionvision.com and start seeing lymph nodes like never before. Are you thinking about applying to a pathologist assistance program and feeling a little lost? That's why I created the Path to Path A, your PA school application blueprint. This is a step-by-step prep course that gives you everything you need for a strong application. From finding shadowing to writing a standout personal statement to prepping for interviews, this course was made to help you feel informed, confident, and ready. Visit www.thepathtopatha.com to join the mailing list. You'll be the first to hear when the course launches. Your path starts here. And now for the rest of my conversation with Dr. Derrick Forchetti on the People of Pathology podcast. All right, so speaking a little bit about AI, when you do that, there's sometimes a fear from people that might replace pathologists and might replace, other medical providers, laboratorians, things like that. And I've heard you say that you think of AI as a tool that helps you to do a better job. Can you talk more about that?
Sure. Yeah, I'm really excited about it because I just look at it as another tool in our toolbox. Yes, it may replace some of the things we do, but it's not going to replace us as people. I've gone through I did. I wasn't not quite an old enough to go through the IHC change, but I do
Mhm.
remember people saying when immunohistochemistry came out, people were saying that it would replace pathologists. You wouldn't need them anymore. You would just need immunostains,
Oh, wow.
and that didn't happen. And I did live through the molecular sort of era where people, in fact, one of an oncologist in our local community told me once that we're not going to need pathologists anymore. We'll just do the molecular tests and we won't need you guys anymore. And that didn't happen either. But all of those things, just those tools help me do a better job. You know, if I have an immunostain, now I can make a more accurate diagnosis. If I have molecular testing, the patient gets better treatment. So I view AI as just another tool. It's never gonna that machines and people will always be better together. So it's never gonna completely replace people. Yes, it will change the way we work, but it's just I feel it's just gonna help us work smarter and better. It's kind of like self-driving cars. Totally autonomous self-driving car maybe isn't the greatest idea, but at the same time, you know, people are don't pay attention and have accidents. But if you mix people with the car that has intelligence in it, you know, smart sensors for lane changing and things, and that to me, that's better than either one of those things by themselves. So that's the way I view AI. It's going to be, plus the tool is always going to be better for patients and pathologists and for the lab.
Okay. I love that. That's a great analogy.
Yeah.
You When I think about AI, it's, you know, a lot of people are making, a lot of different companies are making different tools that are nice, but maybe aren't necessary, or maybe don't, like you were talking about earlier, they don't really, increasing accuracy sometimes isn't the end goal sometimes. But
Mhm.
at the same time, I think it's useful to try out things, and that's how you make them better. Right? Because if something comes out and you go, we don't really need that tool, and then that's the end of it. But you could also try it out, say, okay, this part works, this part could be better. We don't need this other part. You know what I mean? And then they make another iteration that is more useful, that is better. You know what I'm saying?
Yeah. Yep. Definitely. It's definitely an iterative process, and maybe the first idea isn't that great, but it forks off into a different direction, and you find something that really is
Yeah.
useful. So yeah, I would agree with that. And I think that's why it's good for people if you have the knowledge and the desire to sort of do some of these things yourself too. I mean, obviously you don't want to do something that's going to be dangerous and hurt patients, but there's no harm in developing your own tools, seeing what you can do with your own images and things like that, because like you said, it might spark a different idea, a better solution that hasn't been out there before. So
Mhm. Okay. Okay. Well, over the last few years, you've been involved in a project that uses digital pathology and AI to predict colon cancer risk in patients with tubular adenomas. All right. So, what was the origin of this project?
So the origin was me just in my daily sign out noticing certain patients that had colonoscopies at, you know, over time. And then all of a sudden now I'm looking at a colon resection with a colon cancer. And then of course, other patients that you look at and you look at the history, they've had screening colonoscopies for 20 or 30 years, and they're always just low grade tubular adenomas. They never got cancer. So it just was curious to me, like, what is the difference between these two groups of patients? They're supposed to be exactly the same. They weren't high risk patients. They didn't have Crohn's disease or some known risk factor for colon cancer, but yet some of them all of a sudden after two colonoscopies, now they have colon cancer. So my thinking was maybe there's something subtle, some subtle differences that we can't see with our eyes. And that's why I got the idea maybe a machine learning type system could look for those very subtle differences between different patients and see something we're not seeing. So that was the theory anyway, that there are some subtle differences that you just can't detect with our human eye or whatever technology we have today, microscopes that could help us predict which patients are at higher risk. And then so I gathered up some patients in the two groups and scanned them, and then waited for a while until I eventually found a couple of people. One person I work with, he's a computer scientist, and then pathologist. Her husband is a mechanical engineer who's really into machine learning, and I got them involved to help me with the technical part of the project. So that's when it really took off.
Okay. And then what kind of time period are we talking about here between when you had this idea and it started to, and like you said, it took off, it started working?
Ugh. Yeah, geez, the idea started probably 7 or 8 years ago,
Oh,
and I gathered the information and sort of had it sitting there waiting, hoping that somebody. I tend to like assume I can do more than I can. So, at first I thought I'll just do it all myself, but it's
right.
obviously, I'm not smart enough to do that. So I was just looking for some people to help. And the other thing that helped is then I worked for a time in Toledo, Ohio, and they have a University of Toledo Medical Center has a pathology residency program. So I also found a pathology resident that was an engineer, had a bachelor's degree in engineering, and he was really interested in this project too. So probably within the project started maybe 7 or 8 years ago with just my idea and my information. And then within the last year or two, it really came to fruition with a poster presentation and some papers and things like that.
Okay. I mean, this is a good example of what we were talking about earlier, because you had the idea and you're maybe playing around with it a little bit until you found people you could collaborate with. And that's when it started to gain some momentum.
Yep,
Yeah.
for sure. Yeah.
Yeah. Are you able to explain, like, it probably would be better visually, but are you able to explain like how it works, how it analyzes the image?
Yeah. So basically, we have two groups of patients. Like I said, no known risk factors for colon cancer. We scanned all of their tubular adenomas from screening colonoscopies. We reviewed them to make sure that we didn't miss any high grade dysplasia or something like that. And then we took the whole slide images and broke them into just thousands and thousands of image tiles, different small tile pictures of those adenomatous areas. And then, so I think we had probably 100,000 image tiles within each group or something like that. And then so then you tell the algorithm which tile this, if it's supposed to belong to group A or group B. And it was a neural network. So it does whatever it does. You don't really know what it's looking at, but it looks at each tile and classifies it where it this is supposed to be A, this is supposed to be B. So the neural network decides what features it's going to look for to put the image tile into one category or the other. And then, so that was like 80% of the tiles. And then we held back some tiles for testing. So then we put unknown tiles into the algorithm and just measured how well it could classify them into A or B. I guess it's similar, like you have, millions of pictures of dogs and cats, and you try to teach the computer to say, well, this is a dog, this is a cat, but you hold some of those pictures back.
Okay.
And then you give them brand new pictures it's never seen before, and you measure how accurately does it call this one a dog and this one is a cat. You know what it's supposed to be, but and then you see, okay. And so that's basically the idea. So, and then it turned out to be pretty accurate. It could classify unseen images pretty accurately as to whether those patients were at higher risk for developing colon cancer or not. It's almost too good. So we're a little worried that it's overfitting on just our data. So we want to try to get images from other labs. We contacted a couple people to do a follow-up. There's always a problem with overfitting. I can't show you the picture, but somebody made this picture of a mattress that's like shaped exactly like a person. And that mattress is perfect for like one person, but it doesn't generalize. You can't sell that same mattress to other people because it won't fit them. If it's like a trace outline just for you, and then that's great for you. So that's what we're worried about, that the algorithm is actually it's too good and it doesn't generalize. So
I see.
that's what we want to look at next. But I think the analogy of like, Facebook or something, or Google trying to tell if your picture has a cat or a dog in it, that's kind of the idea of what we're doing. How well can we categorize those two images?
I see. Okay. So
If that makes sense.
I think so. Yeah. So now that you have these results and you're talking about you getting data sets from other labs, is that kind of the next step? Are you looking at but the potential for this algorithm for maybe other cancer types, something like that?
Yeah, other cancer types or this cancer type. I mean, what would be I think would be really nice. Of course, this would have to be thoroughly evaluated but if this kind of algorithm works, you could put this information on a pathology report. It's like we feel that you're even though this is supposed to be a low risk patient, we feel that this biopsy has features that make this patient slightly higher risk to develop colon cancer. I mean, obviously that's way down the road. We would have to make sure that we're not making misstatements. But yeah, so the goal would be to eventually develop something that would actually help people, help doctors, help patients get better care, whether it's colon cancer or some other system. Can you enhance your pathology report to give them a little more information? Because right now it's just sort of you're catching everybody in a giant bucket with colon cancer. You get screening every 5 years, and you're sort of assuming that everybody is the same, but we know they're not. Younger people are getting colon cancer, and there's something going
Yeah,
on. So
right. So you're talking about like more personalized medicine.
it would be personalized medicine. And of course, I would never put this information on a pathology report today because we haven't thoroughly evaluated that claim. But if something like this were to turn out to be true and accurate, then I think you could personalize your pathology reports with this information.
Okay. Okay. I like that. So,
Yeah,
well, let's keep going along those lines because I want to end with kind of looking at what the future might hold. And it sounds like this is part of that. In the future, you could have more personalized pathology reports. So you're involved in pathology, informatics, AI research. When you look at the next, I don't know, 5 to 10 years, what kind of developments in digital pathology or artificial intelligence are you most excited to see?
definitely. I'm really excited about any sort of predictive help that we can give. I think a lot of the cancer studies are always based on people that already have cancer
Right.
or, they've already been treated. So how well do they respond after treatment, which is all really important. But there's a gap, especially with some of these like pancreatic cancer and ovarian cancer. It's so hard to screen for those things and predict who might be at risk for them or not. Of course, there's lifestyle factors and things that are risks, but it just seems like most of those patients present at a time when their cancer is already fully progressed, and it's can be a really sad situation. So I'm really excited about, and it might not even be just digital pathology, but using clinical data or any way that we can use technology and AI to sort of better triage patients and stratify risk and let them know you need to be watched more closely because you're at risk for X, Y, Z. So that's one of the things that really excites me. I hope we can get there. I had a relative that died of pancreatic cancer, and I'm sure everybody knows, someone that's died of cancer.
Yeah.
And sometimes you just feel like it's hopeless because we don't have any way to screen for these things. So that's one thing. I'm also just excited, I guess, a little bit selfishly about just technology helping me to work better and smarter. I feel like sometimes people are inconsistent depending on what's going on. If you're under a lot of stress, if you're rushed, you're not always doing the same job. If you have a lot of time to think and speculate, I'm afraid if, we're human, so we're going to make mistakes. And so I'm really excited about any tools that will help us avoid those mistakes or help us. Like I said, it'll be a synergy between people and machines so that
Yeah.
will be better. Pathology, I feel like especially is really difficult because there's literally no room for error. You have to be right all the time, but you can. I mean, you're human and you're never going to be right all the time. You're going to make mistakes. So I'm pretty excited about anything that will help us reduce that error rate down to as close to zero as possible.
Okay. Okay. I can definitely understand that.
Yeah.
Um, I'm just thinking like these examples that you're giving. You're a pathologist. You teach pathology residents. Like for these residents coming up, even new pathologists, how do they prepare for that future?
I tell them to stay curious and to keep learning. don't listen to the people that say you won't have a job or you shouldn't go into pathology, but just stay involved, stay as curious as you can, learn as much as you can. You don't have to love it, but you will have to deal with it. So my whole stance is just it, the changes are going to happen whether you like it or not. I mean, things are changing. There'll be some future development that will change pathology and medicine. It's going to happen whether you want it to or not. So you can either I mean, so it's up to you how you want to deal with that. You can embrace it and learn about it and be part of it, or you can, either refuse to acknowledge it and pretend it's not happening or hope it'll go away.
Right.
So I just recommend that, you don't just, your attitude is the most important thing. You don't have to be the smartest person in the world. You don't have to know everything about everything or even love it, but you just have to have the attitude that this is going to happen whether you like it or not. So you can embrace it. You can learn as much as you can about it and have a positive attitude and try to see the benefits rather than the downsides.
Okay. That's great. That's great. I love that. That's great advice. Dr. Forchetti, this has been a very interesting conversation. I appreciate your time and coming on the podcast today. So Dr. Derrick Forchetti, thank you very much.
Thank you so much. I'm so honored that you would want to speak with me. I'm very grateful. Thank you so much.
If you're looking for another episode of the People of Pathology podcast to check out after this one, here's a clip from my interview with Dr. Kenny Ojuwu, as she talks about what happens when a pathologist takes a microscope to a colon cancer screening health fair and shows the patients the microscopic images.
This was also during the era where I think pathologists were really trying to be more visible, right? So I was in residency at the time, and at that time I had just learned of Dr. Legia Joseph. Mm-hmm. And because I was exploring this idea of what would it look like if patients saw their own slides. And I stumbled upon her first publication on patients looking at their own slides and how it helped. So I was in a county facility where resources were not as present. So we thought about what does it look like if we took microscopes to a health fair. So what we ended up doing is bringing pathology booths to health fairs and having patients look at, we focused initially on colorectal cancer. So had them look at a normal biopsy, a tubular adenoma, a TA, and then a cancer. And we had endoscopy pictures that correlated with each of the slides and had that conversation about what is the actual workflow when you go for your colonoscopy and what is it that we're looking for to diagnose. Whether it's just a TA that they got out, so that's great, they caught the precancer versus the actual cancer. And it was received very well. People felt like they learned and they enjoyed the conversation.
You can hear more from Dr. Kenny Ojuwu in episode 207. All right, big thanks to Dr. Derrick Forchetti. I think this was a really important conversation because a lot of people in medicine, and especially in pathology, are trying to figure out what the future is going to look like with AI, digital pathology, and predictive analytics becoming more and more common. One of the things I really liked about this conversation was hearing about how mentorship played such a big role in his career. It's a good reminder that so many people end up in pathology because someone took the time to teach them, to show them what the field was about, and to help them see how pathologists impact patient care. That theme comes up again and again on this podcast, and it really shows how important mentorship is in our field. I also thought it was interesting how his interest in technology started long before medicine, going all the way back to early computers, and then eventually found its way into his career through informatics, digital pathology, and AI research. I think that's something a lot of people can relate to now, especially students and residents who grew up with technology and are starting to think about how they can combine those interests with a career in pathology. We also talked about one of the biggest questions people always ask: is AI going to replace pathologists? I really liked Dr. Forchetti's perspective on this. He compared AI to other technologies that were once new and maybe a little intimidating, things like immunohistochemistry and molecular diagnostics. Those technologies didn't replace pathologists. They made pathology more powerful, more accurate, and more valuable to patient care. and AI will likely be the same kind of tool. It's something that will help us make better decisions, catch things we might otherwise miss, reduce errors, and ultimately provide better care for our patients. But probably the most exciting part of this conversation was his work on predictive analytics, using digital pathology and AI to predict colon cancer risk in patients with tubular adenomas. The idea that we might one day be able to not just diagnose what's there today, but actually predict what might happen to that patient in the future is a really powerful concept. That moves pathology from being a purely diagnostic tool into being predictive and more directly involved in guiding patient management and personalized medicine. If there's one takeaway from this episode, I think it's the advice Dr. Forchetti gave about staying curious and not being afraid of new technology. The field is going to change. It always has. Pathology today looks very different than it did 30 or 40 years ago, and it will look different again 20 years from now, or even 10. The people who are going to shape that future are the ones who are willing to learn, adapt, and get involved. This is a really interesting time to be in this field. There are a lot of opportunities to get involved in informatics, digital pathology, AI research, workflow improvement, data science, and education. You don't have to be an engineer or a programmer to be involved, but you do need to be curious and willing to learn how these tools work and how they can improve patient care. As always, I'll have links in the show notes to everything that we talked about today. Don't forget you can follow the show at People of Path on Instagram, or you can just connect with me on LinkedIn. Thank you for continuing to share the show with others. Together, let's inspire the next generation of pathologists and laboratory professionals. This show is a member of Health Podcast Network. Thanks for listening. I'm Dennis Strength, and I'll talk to you next time on the People of Pathology podcast.